our esteemed president has his anatomy final right now, so he can't be here, unfortunately. I told him he should have come in. Yeah. Anyway, so I'm going to leave the meeting today. I won't, sit up here and bash you guys for not showing up to SSC. That's not our place. No scary announcements. Other than that, we do have the Scrubs party next Thursday.
Yeah, so it's going to be actually at Nick's house next Thursday. So, yeah, wear scrubs. It's a lot of fun. It's like wearing pajamas. Party.
Yeah.
That's how I look at it.
Do you know what time it's going to start at?
9:30. Whatever.
Yeah,
Party time.
earlier.
Maybe earlier.
Hey guys.
I was looking at the sign up. I'm so glad all of you guys are signing up, but for the afternoon shift we need a driver to drive the 3 other people who signed up. So if you have a car and are free this Saturday in the afternoon, there's one more IUTA spot. It's like a great opportunity to really get some hands-on experience with other Dow students. So if you're free, sign up, just so I can like that and then get it.
It's close to stuff too, right?
Anaheim?
Yeah, it's pretty close.
Anaheim.
So one of the better opportunities if you haven't done it.
Not a lot. There's not a lot of IUTAs either, so this is like, the opportunity.
Alright, and our speaker today is Dr. Boros. She will be talking to us about intro to oral pathology, what it is, and if we're interested in future and how it works for us. So, thank you. Okay. Well, you guys can start.
Alright, so my name's Audrey. I am a boarded oral pathologist, and I'm just going to talk to you guys a little bit about an introduction to oral pathology. Really informal, so if you have questions along the way, feel free to ask. So basically, what is oral pathology? It's one of 9 dental specialties that is recognized by the ADA. What we do as a group is we identify and manage diseases that affect the oral cavity and the maxillofacial region, so the jaws, basically, and we investigate the causes, the processes, and the effects of these diseases. So it's considered both a specialty of dentistry and of pathology. And so you might be interested in how to become an oral pathologist. So you have to complete your DDS degree. And then after that, we have to go through 3 years of postdoctoral training in an accredited program. And then we have to pass a board exam. And then you are a board certified oral pathologist. So once you are an oral pathologist, what are your options? So basically there's 2 avenues that you can go. You can become a dental school faculty. The oral pathologist here is Dr. Parrish. I don't know if you know him, but he does a lot of research. So you can do research, patient care, teaching, as well as diagnostic practice, so lab diagnostics. And then you can also do private practice, which is mostly what I do full-time. So I diagnose specimens that are sent to our lab by oral surgeons. And basically, I'll give a diagnosis. Is it cancer? Is it not cancer? And then we also do patient care, like clinical oral pathology is referred to, or oral medicine is also sometimes called oral medicine. So just a little bit more specifically, there are several stages for evaluating oral lesions. I don't know if you guys have done any oral exams, any oral cancer screening exams, but that's the first start. You have to basically be able to recognize that there is an alteration from normal, and then you have to describe the lesion that's there, and then generate something that's called a differential diagnosis, which is basically an educated impression of what you think the lesion might be. And then after you have that, you have to send the patient for a diagnostic procedure, and that's usually a biopsy, something that an oral surgeon will do. even periodontists or general dentists sometimes do these procedures. And then we as oral pathologists take that tissue, analyze it, and diagnose it. So that's basically the process. With that diagnosis, then we have an idea of how to treat the patient, and then you can follow the patient as well, which is very important. So basically, we can classify diseases based on etiology. This classification is also really helpful when we're formulating a differential diagnosis. The three main categories are developmental. Usually we're talking about congenital or hereditary conditions. And these usually present as symmetrical or lesions involving the midline. And usually present, in younger patients, but they can present in older patients. Then there's a category of reactive, which is a really broad category. It includes inflammation, so like basically disease caused by periodontal disease or a cavity that's infected the root and is now in the bone. Infections, so things like viral infections, fungal, bacterial. Reactive can include trauma as well. And also autoimmune conditions can show up in the oral cavity. We just diagnosed a case of lupus today that was involving the oral cavity, so that's really interesting. And then, of course, neoplastic. So two main subcategories of neoplastic conditions. Is it benign or malignant? The most common malignancy, does anybody know in the oral cavity? What it is, like oral cancer? So it's squamous cell carcinoma. It's the same kind of carcinoma that can affect your skin. So it just happens to occur in the mouth. So you can also classify diseases based on location. Diseases can involve the teeth. They can involve the bones, so namely the mandible and the maxilla. They can involve the oral mucosa as well as the oral submucosa. So the submucosa includes, connective tissue, adipose tissue, different vessels, nerves. All these things can result in pathology. And also salivary gland tissue. So I'm going to go a little bit into the specifics of, and some examples of some pathologies that occur in these locations. So the first one we'll talk about is pathologies that are associated with teeth. I'm just going to briefly talk about them and give like a couple examples of each. So here, when we're looking at the teeth, we have to, again, know normal from abnormal. So we want to pay attention to the number of teeth in the mouth, the appearance, the eruption timing, and the sequence that the teeth are erupting. And any deviations from these basically is a pathology, or you have to figure out why there's a deviation, and it can be either a local pathology or a manifestation of a systemic disease. I don't know how many of you guys have seen panoramic x-rays. Here is a fairly normal panoramic x-ray. You see the teeth are nicely lined up. It's mixed dentition, and there's no pathologies in the jaw that we can see. So I just want you to take a look at this and then compare it to this. So here we have a panoramic x-ray. This is a 10-year-old child, and what do you guys notice? Like, yeah, there's actually a ton of teeth. So it's not like, do you guys know how many teeth are usually in the mouth? 32, okay, so, and then you have your mixed dentition, so sometimes more, in the jaws. But here we have, I think I counted it at one time, and it was like close to 80. Like this patient has way too many teeth. So this is a manifestation. It can be several conditions, all systemic conditions, but this patient happened to have something called cleidocranial dysplasia. Have you guys ever heard of that before? No. Yeah, so other manifestations would be dysplasia of the clavicles, so the patient can actually touch their elbows together, and several other manifestations. So this is really interesting. It was a case that actually a pedodontist had sent to me when I was a resident. Okay, so here's another pathology that affects teeth, another condition. Anybody want to describe what they see here? Like Like it definitely doesn't look normal, right?
Yeah.
So there's like a little bit of brown, maybe staining. If you look closely, it's not smooth. The teeth are not smooth. So this is actually a condition called amelogenesis imperfecta. Has anybody ever heard of that? So it's a condition whereby the process of enamel formation is disrupted, and there's many different types, but this is one of them. There's many different subtypes. So this is amelogenesis imperfecta, and there's also a similar condition called dentinogenesis imperfecta, and can also be related to osteogenesis imperfecta. So it's really important to make these observations because they can have systemic manifestations. So moving on to lesions of the maxilla and mandible. So normally these, our bones are bilateral, they're symmetric, there's not any asymmetrical swellings. So when you're looking at somebody, they're relatively uniform, right? So we use radiographs to detect early jaw lesions, and when we see jaw lesions, we want to know the location, the dimensions, the demarcations, the appearance and the pattern of these lesions. I don't know how much experience you have with radiographs, but if we see a lesion here, let me just grab my... Does anybody know what a descriptor would be to use to describe this term right here compared to here? So it's pretty dark, right? So you'll definitely learn this in dental school, but it's good to know a couple of the terms before you go. So this is something that we refer to as radiolucent. So this is actually a lesion in the jaw. Usually it'll look like this, but this whole dark area is a pathology, and that's called, to describe it, we call this a radiolucency. And then the opposite of radiolucency, here's the jaw again, and this area here is a lot more dense. So does anybody know the opposite of that? Good, yeah, radio-opaque or radio-dense. And then here's a lesion here, and it's kind of mixed. So it's both radiolucent and radio-opaque, and we just call that a mixed lesion. Here's an example of a lesion that has a well-defined or clear border. So take this, and you can see the lesion really clearly here, and compare it with this lesion. This is normal bone, this is not normal. So this is diffused. You can't really tell where it starts, where it stops. So we describe that as ill-defined or diffuse without clear borders. And then talking about the location, is this well-defined or ill-defined? Well-defined, but it's associated with, this is a tooth, right, in the mouth, and this is a tooth that's still in the jaw. So what's that? An impacted tooth, right? So it's an impacted tooth with a radiolucency. We call that pericoronal. It's around the crown, and it's a radiolucency. And then here's one near the apex of the tooth. Does anybody know how you describe that? So peri, beside, apex of the tooth, periapical. And then one that's in between roots, another word for roots, radicular. So it's interradicular. So all these are examples of lesions of the jaw. Here's another one where you have it's a similar picture. It's well-defined, and it's around the crown of an impacted tooth. But the one thing I want to point out here is that there's just one circle. So we call that unilocular, one locule. As opposed to this lesion here, this entire area here is one lesion, and you see there's lots of, it's almost like bubbles. That's called multilocular. So when we're describing lesions in the jaw, we ultimately want to combine several terms. We want to include measurements, the location, and any effect on surrounding structures to fully describe the lesion. So for example, we say a 1.0 by 1.0 centimeter pericoronal unilocular corticated radiolucency of impacted tooth number 32. You should be able to have a picture in your mind, because when the surgeon is sending us a specimen, it's really helpful for us to know what it looks like clinically. So that's the reason why describing lesions are really important. So here's an example of a jaw lesion. And how would you describe this? We just went over one of the terms. with many bubbles. Multilocular, perfect. So it's a lesion that extends from the distal of, looks like tooth number 28 maybe, all the way up to, the anterior border of the ramus. And it's multilocular and is fairly well defined. So that would be really good to provide that information to us as pathologists. And then under the microscope, we see here's epithelium, here's connective tissue. So this is a cyst. Its epithelial lined cavity is always a cyst. And this actually is very characteristic of something called, does anybody know? An odontogenic keratocyst. Have you guys ever heard of that? Okay, good. Well, I'm teaching you a lot today. So, alright, so this is an OKC, or an odontogenic keratocyst, also known as a KCOT, or keratocystic odontogenic tumor. It's kind of in between a cyst and a tumor, and basically clinical features: wide age range, slight male predilection, seen in the posterior mandible usually, like we saw in that case. Small lesions can be asymptomatic, which is why it's important to do routine radiograph screening, right? And then large lesions are usually, if they're large enough, they will be symptomatic. This should be symptomatic, and associated with pain, swelling, and drainage as well. There's a condition which people may have multiple of these lesions in their jaw, so all over the place. Anybody know what that condition would be? Alright, so it's called nevoid basal cell carcinoma syndrome, or Gorlin syndrome. It's actually a mutation in the gene. It's autosomal dominant, and there's also a lot of systemic manifestations, such as a lot of basal cell carcinomas, multiple OKCs, like we just talked about, intracranial calcifications, and some other skeletal anomalies. So here's an example of a patient with this syndrome, and you can see that she has several radiolucencies in the jaws. This tooth is superiorly displaced up into the sinus. Big lesion here. So this patient has multiple OKCs, and she was worked up, and she ended up having nevoid basal cell carcinoma syndrome. This picture is a little bit graphic. These are the little basal cells here, and then this is what happens when the basal cells progress into the larger lesion. So it can be really deforming. So moving on to mucosal lesions. So just histologically, what we have here is the mucosa, so the lining of your mouth, stratified squamous epithelium, and then the submucosa, so the connective tissue that's under the lining of the mouth. So here's a lesion. I'm just going to go over some descriptors of, lesions. So here's a dark spot here. Does anybody know what we call a flat dark spot? So flat and dark, we term it the macula. So it's a flat area of color change, usually black, brown, or gray. This happened to be biopsied. You have to biopsy in order to know what this is. And it's just like a mole on your skin, but it's in your mouth. Here we have a lesion of the lateral border of the tongue, and it's white. Does anybody know what that is? A white patch is termed leukoplakia. So leuko refers to white, plakia refers to patch. And this happened to be dysplasia, so it's a pre-malignant lesion. It's pretty subtle, but this is a high-risk area for oral cancer. So in order, you can't tell that just by looking at it. You have to biopsy it because it could be a number of things. So leukoplakia, white patch, you guys will definitely learn that in dental school. That cannot be scraped off. Here's another example of the gingiva. Again, this was a pre-malignant lesion, a white patch, and this has to be biopsied. The opposite, basically, of leukoplakia is a white patch is a red patch, or an erythroplakia, and that is describing this lesion here in the lateral border of the tongue, so it's really a lot more red than here. And this is actually a squamous cell carcinoma. So it's really important to be able to recognize these lesions and definitely biopsy them. Here's an erythroplakia, or a red patch of the gingiva. This was carcinoma in situ, so it was just the stage right before cancer. Again, this has to be biopsied. Here's a descriptor of a lesion, and it's attacking the surface epithelium. So you guys probably have all heard of something called an ulcer, and that's basically what an ulcer is a defect in the tissue where the covering is absent. So this does not have any mucosa, it's the submucosa that you're seeing. And then what about this lesion here? We've got lots of these little finger-like projections. Anybody know what that's referred to as? How would we describe this? So it's papillary. So a lesion with a raised lesion, finger-like projections, we describe that as papillary. So this is a papilloma. Again, I'm sure you guys have heard of like a wart, right? A wart is also known as a papilloma, and this is basically a wart in the mouth. And then we have a big lesion here of the gingiva, and it's round and it's raised, and we refer to this as a nodule. So it's a solid swelling that's larger than 5 millimeters. If it's smaller than 5 millimeters, we call it a papule. So again, we want to be able to describe what we see in order to have a common language between the clinician and the pathologist. For example, 0.8 by 0.8 centimeter, well-defined nodule of the buccal gingiva of tooth number 8. So you should all be able to picture size. Nodule we know is a raised round lesion on the gingiva of tooth number 8, so the front gingiva. So here we have an example of a lesion, and it's on the lateral border of the tongue. And does anybody have any ideas what this might represent? Okay, so basically, do you guys know the high-risk areas for oral cancer yet? Yeah, so definitely the tongue. So specifically the lateral border of the tongue, like this. The ventral tongue, so that side of your tongue, the floor of the mouth, and then the tonsillar pillars and the soft palate. So those are all the high-risk areas, and any red patch or white patch that you see in that area has to be biopsied to rule out cancer or premalignant disease. This is a squamous cell carcinoma. So like I said, that's the most common cancer, that's oral cancer of the mouth, oral cancer, and this is an example of that. So it's, ultimately what we would want to do is detect it earlier, and I'll get into that in just a minute, but it's the most common malignancy of the oral cavity, squamous cell carcinoma. It's painless until the disease is advanced, so patients tend to ignore things that they see in their mouth that aren't causing pain. So it's up to you guys when you become clinicians and your hygienists to do thorough cancer screening exams, because if that was caught at an earlier stage, you could just cut it out and it would be fine. But this patient now needs like have his or her tongue removed and a neck dissection. And at this size, when it's greater than 1 centimeter, it's likely already metastasized. So to at least the regional lymph nodes. So high-risk locations we talked about: lateral border of tongue, ventral tongue, floor of mouth, soft palate, and tonsillar pillar. And basically it's 41,380 cases in the U.S. Oral cavity and oropharyngeal squamous cell carcinoma causes an estimated 8,000 deaths. It affects males more than females, and the 5-year survival overall is 62%, and it's the eighth most common cancer in men, so it's pretty common. And the reason that we want to, detect it earlier rather than later is because if you see here, the 5-year survival rate depends largely on the stage at which it is detected. So all stages 62, but if it's small, really good chance of survival. If it's regional, so the regional lymph nodes, it's spread just locally, less than 60%, and distant is 35%. And when you compare that overall with breast, we all hear about breast cancer, colorectal cancer, even melanoma, overall, it's a 5-year survival is lower than all of those. So what does that tell you? That basically tells you that we're not doing a good job screening our patients, right? So you see that the overall stages here reflect the local disease stage here. So we know the ABCs of melanoma. We're all looking for nevi on our skin that look irregular. And if we see something, we go to the dermatologist and they biopsy it. Well, same thing for breast. Really good chance of survival if it's caught at the local stage. and that reflects all stages, so that tells us that usually it's caught at the local stage. Here we're seeing it's, just slightly above regional, so we can definitely do a better job in screening, and that'll be really important for you guys when you get into the clinic. So what we'd ideally like to do is catch it at this stage. This is also a cancer, but this is much smaller, and this can just be, chopped out, and it won't be a big deal for the patient. It won't affect their speech, it won't affect their ability to eat, that kind of thing. And then here's the second last case that I have. Here's a lesion of the buccal gingiva between teeth numbers 8 and 9. This patient noticed a small bump several months ago, and then it rapidly enlarged. Does anybody have any ideas what this might represent? So if you can get skin cancer, squamous cell carcinoma on your skin and in your mouth, if you saw something like this on your skin, what might you think? Melanoma, right? So this, took a biopsy. Here's the overlying epithelium. Here's the connective tissue, and you see all these cells have a lot of pigment. So you're seeing what you're seeing clinically under the microscope. You're seeing all this pigment. This is melanin. And when you look closely, well, it's a little blurry, but you see this is one cell, and this is a nucleus, and this is a nucleoli. So I don't know if you guys know a lot about cell cytology, but you're not supposed to be able to really see the nucleoli, right? And you're seeing them here. It's almost the size of a normal nucleus, and the nuclear to cytoplasmic ratio, which is just this tiny little rim here, is really big, and that's also another sign of malignancy. And all of them are kind of shaped differently. This one's big, this one's small. That's called pleomorphism. Here's a double cell. This is melanoma. So this patient had a primary melanoma of the mouth, which can happen. The melanocytes in our body, they travel everywhere, so it's not a static thing. You can get melanoma of the oral cavity, of the eye, of the brain. Melanoma can start in lymph nodes, so it's not just a skin disease. This is oral mucosal melanoma, often diagnosed at late stage. Early lesions can mimic benign pigmented lesions like we saw before, like a mole on your skin but in your mouth, so they can look the same. And don't delay biopsy because they're really aggressive and the survival rate's really low. Clinically, usually the high-risk sites for oral melanoma is the palate, the maxillary gingiva, and they usually present as spreading pigmented lesions, but then they rapidly enlarge. This is actually a melanoma as well, but you can't really tell just looking at it clinically because it doesn't have any pigment. So it's actually so advanced that the cells that are causing this melanoma have lost their ability to produce that pigment. So it's a really bad sign. So this is called an amelanotic melanoma. And here's an example of somebody that I saw in residency, and he had a skin lesion of melanoma. He was only like 35 or something, and it metastasized to his mouth. So it can be primary or it can be secondary. Treatment is obviously radical surgery, including jaw resections, so it's not just a small, removal. Often sentinel node evaluation with or without radical dissection. Prognosis earlier is better. Most diseases are diagnosed most of the cases are diagnosed at a late stage, and it's only like 13% survival at 5 years. So if you see a pigmented lesion ever on somebody's palate or gingiva, you need to biopsy it. Okay, so this is the last case that I have. Here is an example of a 15-year-old male, and this lesion was discovered on routine examination by his dentist. It looks pretty innocuous. It's almost like, I don't know if you guys know what a fibroma is, but it's like a little bump of just connective tissue. You can get it from trauma just by biting on your cheeks, that kind of thing. So he saw this lesion and he was like, okay, it doesn't look too bad. But then, and his parents had stated that it had been there for a while. Then he looked on the other cheek when he was doing an exam, and he saw these lesions. So now it's kind of weird that he's got like bumps on both sides, so it's bilateral, or it's symmetrical. Do you remember when he said at the beginning, when you're classifying, diseases based on etiology, if something's symmetrical, what does that usually tell you? Yeah, so it's hereditary, exactly. So developmental, that's the category that we're in. Then he looked at his tongue and noticed these small little bumps and said, okay, we need to biopsy these. So, anybody have any idea what this might represent? A couple syndromes? Okay, so here we have a biopsy, squamous epithelium here, and this happens to be just collections of nerves. The nerves happen to have really thick perineurum, and the diagnosis, you can see it a little bit better here. These are nerves. This is the perineurum around the nerve. It's thickened, and that's diagnostic for something called a mucosal neuroma, and that's a component of something called multiple endocrine neoplasia, which is a hereditary condition, and it's a group of conditions that's characterized by tumors of the neuroendocrine tissues, and the one that presents with oral lesions is MEN2B or MEN3, and it's caused by a mutation in the RET proto-oncogene. And basically, highly characteristic, we see those nodules at the sides or corners of the mouth. So luckily that dentist knew about this condition and knew to biopsy it, because a lot of clinicians, that I've asked before, no, we wouldn't biopsy it, he's probably just biting his mouth, his cheeks or whatever. But it's really significant to know about this condition and to do biopsies when you see anything that's abnormal, because one of the things that these patients develop before the age of 18 to 25 is something called medullary thyroid carcinoma. So 90% of these patients manifest this. And so if they do manifest it, it's excessively aggressive, and the average age of death for patients is 21 years, so it's really young. So luckily, this patient, 15 years old, got diagnosed with this, got worked up. They take out the thyroid because they want to prevent that from happening, because it happens so frequently, and the dentist saved his life. So treatment is prophylactic removal of the thyroid gland. Prognosis depends on early recognition. We know that this type of thyroid cancer has a really poor prognosis, and they also tend to develop pheochromocytomas, which are benign lesions of the adrenal gland, but they cause hypertensive crisis. So that's also very significant. I think that's it. So those are, some neat cases that we've seen, and it kind of highlights the importance of taking biopsies, and, you guys are all really excited to go to dental school, and it's, it is great, but you have to not just focus on the teeth, you have to look in the mouth, recognize normal from abnormal, and when you see abnormal, don't ignore it, because that's the #1 cause of, lawsuits is failure to diagnose. So when you see something abnormal, if you don't feel comfortable biopsying it, definitely refer. Okay? That's pretty much it. That's what we do. Any questions?
Do you guys know why, the rate of mouth cancer is higher in men as compared to women? Why the ratio is so?
Yeah, so that's a good question. So there's several reasons. So recently in the literature, I don't know if you guys have heard about it, but oral cancer used to be associated with smokers and drinkers. And the reason that it's been higher historically in males is because more males used to smoke and drink. Actually, if you look at those statistics now, they're changing a little bit, where more females started picking up smoking, several decades ago, and males are starting to realize that it's not good and are starting to quit. So that trend really follows the trend in oral cancer, in the classic oral cancer. But now there's a whole new, and it's actually totally biochemically different from the traditional cancers. It's cancers of the oral cavity that are associated with HPV. I don't know if you guys have heard about that, but they actually tend to affect younger males, so ages 35 to 45, and they are caused by HPV virus that gets integrated into our cells. Luckily, it's not common for the virus to integrate, but it does happen, and it's on the rise. So yeah, that's kind of scary. So.
could usually like be using their jaw. Is that structure not really like they got stripped of their jaw? Is that pretty crucial?
Yeah, no, exactly. That definitely can happen. You can have pathologic fractures, is what they're called. And something like that lesion that I showed you, that big lesion, you know, depending on what it is, if it's something called a neuroblastoma, which is a benign aggressive lesion, you have to resect the whole jaw. It's the whole lesion plus a centimeter on each side. So that patient will have a huge deformity. You know, the oral surgeon will try and reconstruct it nicely, but they're not going to have feeling in that side because you have to take the nerve out, and, you know, et cetera, et cetera. So that's why, you know, we stress it's so important to try and find these lesions as early as possible to minimize those factors.
If the lesion is hereditary, can you test the family to see like how prone you are to getting it, or like is it basically hereditary or
Yeah, I mean, if you know, if your parents, there's so many different types of hereditary conditions that can affect the oral cavity, and it's always, you know, helpful if you have a family history of it. So, I mean, yes, potentially, but it depends on the condition. With the condition that I showed you, just that one example, his parents were not affected, so it was a sporadic mutation, so they didn't know, and luckily the dentist took a biopsy. So.
Just maybe more personal, but like what drew you to like oral pathology versus the other specialties and stuff?
Oh, you know, good question. I did a master's in pathology even before I went to dental school, and in undergrad, I just found pathology fascinating. I think with histology, like I showed you some of those slides, and pathology, it either clicks or it doesn't, and for me it clicked. So it was just something that I always found really interesting. Then my family was, you know, I have a lot of dentists in my family, so I was deciding between medical school and dental school, and I just, you know, decided on dental school, and I didn't even know about oral pathology, and then when I got to dental school, one of my friends' aunt was an oral pathologist. You need to meet my aunt, so I actually work for her now, and you know, I looked into it, and I looked at a couple other specialties as well, but I don't know, it just clicks with me. I think in order to go into the specialty, you really have to be passionate about it. It's not maybe like the most popular or the most common, the most, you know, the best paid, but you have to be passionate about it. Yeah, questions?
Wait, one more. So just to clarify, your job is to identify diseases of the mouth.
Yeah. So what I do on a daily basis is, you know, we have oral surgeons and periodontists and dentists that do these exams. They find abnormalities and they take a biopsy in a little bottle, and that bottle is sent to our lab, and then we take that bottle, we open it, there's a piece of tissue inside, we describe it, and then we send it to another lab, which makes it into a slide, and then we get that slide back, and I look under the microscope and I say, you know, this is a mucosal neuroma, or this is, you know, a fibroma, or this is squamous cell carcinoma. So that's usually what I do on a daily basis. Yeah. So it's kind of an in between between medicine and dentistry. It's kind of right in the middle. You're doing a little bit of medicine, a little bit of dentistry. So it's a neat little niche. Any other questions? Okay. Hope you guys enjoyed that.
Alrighty. Thanks, guys.
So